Hello guys, welcome to my channel. The video in focus today will actually be looking at the anatomy of the heart in a summarized version. So you're going to find that the heart is going to be contained within a fibrous serous pericardium, which is this part here, right? Meaning to say the pericardium is going to have a fibrous part and a serous part. The serous part will further be subdivided into a somatic part or a parietal part and a visceral part, right? The fibrous part of your pericardium will actually be formed embryologically from the pleural pericardial membranes, right? And this fibrous pericardium is actually going to be contained within the medium mediastinum. Remember, the thoracic cavity is going to be divided into a superior mediastinum and an inferior mediastinum, whilst the inferior mediastinum will further be subdivided into an anterior part, a middle part, and a posterior part, right? And this fibrous pericardium will actually be attached to the in front to the sternum via your sternopericardial ligaments. And in terms of its innervation, it's actually going to be innervated by the phrenic nerves, which are also going to be innervating the parietal part of the serous pericardium. Then if you then look at the other layers of the pericardium, you'll notice that for the serous pericardium, you're going to have a parietal layer, which is this one, which is going to be lining the fibrous pericardium. Then you're going to see the visceral part of the serous pericardium. And between those two layers, that is between the parietal and the visceral part, you're going to have a pericardial cavity, which will actually be having pericardial fluid, which will be about 50 mils. It's actually going to prevent friction when you have heart movements, right? And if you're going to have an infection within this region, you're going to have something that is known as pericarditis. And this pericarditis will actually result in accumulation of more fluid within this pericardial cavity. And that is going to actually result in what is known as cardiac tamponade, right? And importantly, on the posterior surface of the heart, you're going to see reflections of the sinus pericardium that are actually going to form recesses. That is the oblique sinus and your so you have the oblique sinus and the transverse sinus. The oblique sinus will actually be a reflection of your serous pericardium around the great veins, whilst the transverse sinus will be a reflection between the arteries and the great veins, right? So that is the pericardium. And if you then look at the innervation of this visceral serous pericardium, it's actually going to be innervated by the autonomic nervous system, meaning to say it's going to be sensitive to stretch and tear, unlike the parietal one, which is innervated by somatic nerves, particularly the phrenic nerve, meaning to say it's actually going to be sensitive to pain, temperature, touch, and pressure, right? Then if you then look at the surfaces of the heart and the borders of the heart, you're going to find that, firstly, in terms of the surface anatomy, the borders of the heart, that is the superior, the right, the inferior, and the left, they're going to be as follows. The superior border, which is being formed by these great vessels, it's actually going to extend from the second left costal cartilage to the third right costal cartilage. Then the right border, which is formed mainly by the right atrium, it's going to extend from the third right costal cartilage to the sixth right costal cartilage. And if you then look at the left border, it will extend from the second left costal cartilage to the fifth left costal cartilage. Then the inferior border will actually join the two lower portions of both the right and the left borders of your heart, right? And if you notice, much of the inferior surface of the heart will actually be formed by the right ventricle, as well as a portion of this right atrium, right? Then in terms of the surfaces of the heart, this is what is known as the sternocostal surface, or the anterior surface of the heart. And you can appreciate that on the sternocostal surface, you're going to see mainly the right atrium and the right ventricle. And also some portions of the left ventricle can also be appreciated, as well as part of the atrium of the left side, which is actually this left auricle. Right. So that is the sternocostal surface of the heart. Then if you look at the base of the heart, which is basically the posterior surface of the heart, which is this one, it's going to be composed mainly of the left atrium, and those are actually the four openings of the pulmonary veins. And you can also appreciate the presence of the right atrium. Right. Then the diaphragmatic surface, where the heart actually sits, it's going to be composed of the left ventricle, which is this region here. Right. Then you have the right ventricle, which is this region, and 2/3 of this diaphragmatic surface will actually be formed by the left ventricle, whilst 1/3 will be formed by this right ventricle. Right. So that is actually the exterior of the heart. And going straight into the chambers now, the heart is going to be composed of 4 chambers. That is 2 atria and 2 ventricles. To make it a bit easy, I'll summarize the development. Remember, you're going to have appearance of 2 endothelial tubes that are actually going to join, and they're going to form a heart tube that is composed of the sinus venosus, which has bones and a body. Then you have the primitive atrium, the primitive ventricle. Then you have the bulbous cordis, which was further subdivided into 3. A conus arteriosus, which was the proximal third, a middle third, which was your conus cordis, and a distal third, which was actually the truncus arteriosus. The sinus venosus would actually be receiving 3 systems of veins, and you'd find that the right horn and the body, they'll actually take part in the formation of the smooth part of your right atrium, whilst the smooth part of the left atrium will actually be formed from incorporation of the pulmonary veins. Then the left side of the horn of the sinus venous will actually degenerate, and it will only persist as the left oblique vein as well as the coronary sinus. We'll talk about those when we get to the venous drainage. Then the primitive atrium will form both the roughened parts of your atria, that is both the left and the right. Then the primitive ventricle will form the trabeculated part of the left ventricle, whilst the proximal third of the bulbous cordis, which I refer to as the conus arteriosus, it will actually form the trabeculated part of the right ventricle. Then if you then look at the middle third, which is actually the conus cordis, it's going to form the outflow tracts of both the ventricles. That is the infundibulum for the right ventricle and the aortic vestibule for the left ventricle. Then the distal third will actually then form the outflow tracts themselves. That is the pulmonary trunk for the right ventricle and the ascending aorta for the left ventricle. Right. So if you then look at this being the right atrium, its interior. Right. It's actually going to have a roughened part which is reached, which is this one, which is characterized by presence of this muscular pectinati, and you're then going to have a smooth part. Right. So you have what is known as the crista terminalis, right, and the sulcus terminalis. So this is the crista terminalis. Right. And the main part of the atrium, which actually lies posterior to this crista terminalis, is actually the smooth part of the right atrium, which we're saying embryologically it's actually derived from the right horn of the sinus venosus. Then if you look at the roughened part, which is this one, this will correspond to the auricular part that you're actually appreciating from this surface, which was our sternocostal surface. Right. Then the right atrium will also have openings for the inferior vena cava, which is this one. Then there's an opening for the superior vena cava. I'm mentioning the major openings. Then you're also going to have an opening for the coronary sinus. And this opening of the coronary sinus, it actually lies in between the opening of the inferior vena cava and the right atrioventricular orifice. Right. Remember, the superior vena cava will actually be bringing blood from the head and neck as well as the upper limbs. It was going to be formed at the level of the first costal cartilage by union of the right brachiocephalic and the left brachiocephalic veins. Then at the level of the second costal cartilage, it was going to pierce the fibrous pericardium. And at the level of the third costal cartilage, it was actually going to drain into the heart. Because remember, we then say that the right border of the heart starts at a level that coincides with the third right costal cartilage. So it still makes sense now to say that this superior vena cava, it actually drains into the heart at the level of the third costal cartilage. Right. Then your inferior vena cava will actually be bringing blood from the lower limbs, the pelvis, and the abdominal cavity. It was going to be formed at the level of the fifth lumbar vertebra behind the right common iliac artery by union of the right and the left common iliac veins, as well as the median sacral veins. It was going to receive some veins within the abdominal region to include the renal veins, the testicular, or rather the gonadal veins of the right side, as well as some veins that will actually be coming from the liver, that are your hepatic veins. It was actually going to pierce through the diaphragm via the cava opening at the level of T8. Then it was then going to drain into the heart at the level of the inferior border of the heart, that is into your right atrium. Right. Then you then find that the coronary sinus is then going to drain the major surfaces of the heart. It was actually going to be formed as a continuation of the great cardiac vein. Right. Then the tricuspid valve is going to be the guard between the right atrium and your right ventricle. And the walls of the right atrium, they're actually going to be thinner as compared to the walls of the right ventricle. Right. And also within this right atrium, there are going to be some fetal remnants to include the fossa ovalis as well as the annulus ovalis. So this being the fossa ovalis, it will actually be a remnant of the foramen ovale. Because remember, for you to partition the atria during embryonic development, you're going to have appearance of a septum primum that was not going to grow all the way down to the endocardial cushion that persisted, or that actually existed between the atria and the ventricles. And with further growth, there's going to be apoptosis in the upper walls of this septum primum. Then you're going to have the septum primum grow and close the ostium primum, that was the gate between the primum and the endocardial cushion. And you're then going to have appearance of another septum from the roof of the atrium, which is going to be the septum secundum. It was just going to grow in such a way to overlap the second opening that actually appeared in the roof of the initial septum. And that little communication that then persists after the septum secundum overlaps that was going to be our foramen ovale. And this fossa ovalis will actually represent a remnant of that. Right. Then if you then look at the right ventricle is actually going to be crescentic as opposed to the circular left ventricle, right? And the main part of the right ventricle is actually going to be trabeculated. And those trabecular cani, they're actually going to be of three types. So you're going to have the papillary muscles, then you have the moderator band, and the third one that is actually unnamed. The moderator band is important because it actually contains the right bundle branch, which is a part of the conducting system of the heart, as it actually goes to join the subendothelial Purkinje fibers. So these are actually the trabecular cani, right? Notice these are the papillary muscles, and the papillary muscles will actually be attached at their bases to the ventricular wall. But at their apices, you'd expect to have these chorda tendinae, right? The chorda tendinae will actually join the papillary muscles to the cusps of the tricuspid valve, which is this one. And the tricuspid valve will actually be characterized by having an anterior cusp, which is this one. Then you have a septal cusp, which is this one. Then a posterior cusp, which can also be referred to as the inferior cusp, right? Then the outflow part of this right ventricle, it's actually smooth and funnel shaped. That is what is known as the infundibulum, that we said was actually going to be formed from the middle third of the bulbous cordis, which is our conus cordis, right? Then these are the papillary muscles. You have posterior papillary muscles, you have septal papillary muscles, and so forth. There won't be any papillary muscles that are actually going to be associated with the pulmonary valves, which are then going to be the guard between the right ventricle and the pulmonary trunk. Right. Interestingly, from this picture, away from what we are discussing, this is the ligamentum atriosum, which is a remnant of the ductus atriosus. It's one of the three functional shunts that you actually find in utero. One of them is the foramen ovale that we said was going to persist as the fossa ovalis in the right atrium. Then the other one is what you see on the liver, the ligamentum venosum, which actually bypasses, or rather takes blood from the left branch of the hepatic portal vein straight to the inferior vena cava and back to the heart. This being the third, it's actually going to bypass the lungs by conveying the blood that is actually within the pulmonary trunk to the aorta, because the lungs at this point will actually not be fully developed. Because remember, the heart will actually start to beat at around day 22, which is the 4th week thereabout, right? So this is one of the functional strands that will actually exist in utero, and it's going to obliterate and persist as a ligamentum atriosum, right? So this is the pulmonary valve, and it's going to be characterized by having 3 cusps as well, right? Then this is the left atrium. More or less it's the same as the right atrium. It's going to have a roughened part and a smooth part. And remember we said the smooth part of the left atrium was actually being formed from incorporation of the pulmonary veins, whilst the roughened part was actually formed from the primitive atrium, which was a part of the heart tube, right? Then it's going to receive the 4 openings of the pulmonary veins, which are now bringing oxygenated blood from your lungs. Remember, you had the pulmonary arteries, the pulmonary veins, as well as the bronchi and the lymphatics and whatsoever, and the nerves at the hilum of the lung, with that arrangement from anterior going backwards being the veins, the artery, then the bronchi. Then if you look at it from above going downwards, you'd expect to see the arteries. Then you'd actually expect to see the bronchi, then the veins more inferiorly. That is for the left. And then for the right, since you had the right principal bronchus actually bifurcating before it got into the lung substance, you'd expect to have an epiarterial bronchus just above the artery and the hypoarterial bronchus just beneath the bronchus, right? So that is your left atrium, just the same as your right atrium. And it's actually going to be separated from the esophagus by the fibrous pericardium of the heart, right? Then this is the left ventricle. And remember I said the left ventricle is actually circular as compared to your right ventricle that we said was actually crescentic, right? So this is the left ventricle. It's actually going to be circular, and it's going to be characterized by having a mitral valve, which is this one, right? Or your bicuspid valve. It's going to have a larger anterior cusp and a smaller posterior cusp. You're going to have papillary muscles, yes, but there are no moderator bands within the left ventricle, right? And the walls of the left ventricle, they'll actually be 3 times thicker the walls of the right, because remember, the left side of the heart is actually part of the systemic circulation, whilst the right side of the heart is part of the pulmonary circulation, which actually works in a pressure system of about 25 millimeters of mercury. So you'd expect the walls of the left ventricle to actually be thicker, since it's actually having blood that is 6 times in pressure that of the right ventricle, which is the reason why for people with tetralogy of Fallot, which is also going to be characterized by an interventricular ductal defect, you're going to have blood moving from the left ventricle going to the right ventricle, which is a low pressure system, and that is going to ultimately result in right ventricular hypertrophy, because the walls of the right ventricle, they are not made in such a way to sustain the high pressure of the blood that is actually on the left side of the heart, right? That is part of your systemic circulation, right? So this is the left ventricle, circular. It's going to be having thicker walls, and you have these trabecular cani also giving rise to the roughened parts of the left ventricle. And interestingly, the aortic valve is then going to separate the left ventricle from the ascending aorta, and it's actually going to be the same in terms of shape and structure with the semilunar valve of the right, which was going to be our pulmonary valve, right? Then so these are the valves. They're actually folds of your endothelium, right? And also in the heart, you're going to have parts that are going to work as part of the conducting system of the heart. So these are the valves from this picture before we actually get to the conducting system of the heart. These are the valves, right? This being your tricuspid, this being the mitral valve or the bicuspid valve. You can actually get mitral valve stenosis, and mitral valve stenosis will actually result in left atrium hypertrophy, and that's going to actually compress on the esophagus. Because remember, we said the esophagus actually lies behind the atrium, being separated from it by the fibrous pericardium. That is going to result in dysphagia, dyspnea, as well as something known as Ortner's syndrome. That's going to be more or less a cardiovocal problem, because you actually affect the left recurrent laryngeal nerve as well, right? So that's going to be characterized by hoarseness of the voice, right? So before we talk about the coronaries, the coronary arteries, we'll talk about the conducting system of the heart, whereby the heart has its own intrinsic pacemaker activity. So you have what are known as cardiac myocytes that are more or less striated whatsoever, just like a skeletal muscle, but they're going to be bifurcated, forming the intercalated disc. But you're going to have the SA node, which is this one, which is just to the right of the crista terminalis, right? Then you're going to have the atrioventricular bundle, which is in the lower part of the interatrial septum. Then you're going to have atrioventricular node rather. Then you're going to have the atrioventricular bundle, which is then going to bifurcate at the lower border of, rather at the superior border of the muscular part of the interventricular septum into a right bundle branch and a left bundle branch, right? So cells within these parts, they're actually going to be smaller than the normal cardiac myocytes, and they're going to contain fewer myofibrilles and intercalated discs. Then the cells of the Purkinje fibers are actually going to be larger than the adjacent contractile myocardial cells, and they're going to be more pale staining due to abundant glycogen. The cardiac myocytes, they actually have glycogen themselves, but you'd find that the Purkinje fibers will actually have more abundant glycogen, giving them a more pale staining appearance, right? So an impulse is actually generated in the SA node, and this SA node, interestingly, in embryonic life, the body of the sinus venosus and the right one, they actually function as the pacemaker prior to formation of the SA node. And it will actually make sense to say this SA node, embryologically, it will be developed from the right one of the sinus venosus, because we say it was actually going to form the right atrium, right? Its smooth walled part, right? Then the heart is going to be supplied by the coronary arteries. So you have a right coronary artery and a left coronary artery. These are actually going to be branches of the ascending aorta, with the right coronary artery actually being a branch of the anterior aortic sinus, whilst the left coronary artery will be a branch of the left posterior aortic sinus. And the left coronary artery is actually usually larger than the right, and it's actually a short vessel that is then going to divide into a circumflex and an anterior interventricular branch. This anterior interventricular branch, in a third of the population, it actually ends at the apex of the heart, whilst in another population, or 2/3 of the population, it will then extend to the inferior surface or the diaphragmatic surface of the heart and end by anastomosing with branches that are actually coming from the right coronary artery. So this being the right coronary artery, it's going to exist in the right atrioventricular groove, and at the inferior surface of the heart, it extends to the diaphragmatic surface to continue as the posterior interventricular artery. And that will actually occur in 90% of the population, whilst in another 10% of the population, that posterior interventricular artery will actually be a branch of the left coronary artery. And so that's known as right dominance and left dominance, respectively. Then in 65% of the population, you'd find that the right coronary artery will give you the branch to the SA node, whilst in another 35% of the population, the branch that will actually supply the SA node will actually come from the left coronary artery, right? So the right coronary artery will supply the right atrium, it will supply the right ventricle, it will supply parts of the posterior parts rather of the interventricular septum, except the apex, which is actually supplied by the left coronary artery, right? So this is a left dominant system, and notice the posterior interventricular artery, it's going to be a branch of the left coronary artery. This is a right dominant system. The posterior interventricular artery is actually a branch of the right coronary artery. And we say that was actually going to be the case in 90% of the population. And if you then look at the venous drainage, the left coronary artery will be intimately related to the great cardiac vein. And this great cardiac vein is what continues as your coronary sinus, right? Then the meducardiac veins, they're actually going to be on the diaphragmatic surface, and they're going to be related to your posterior interventricular arteries, whilst this is going to be your anterior cardiac veins, and notice they're related to the right coronary artery. Then these are your small cardiac veins that are being related to the marginal veins themselves, right? Then auscultation of heart sounds. So you'd find that in terms of location, the surface anatomy for the location of these valves, you're going to find the lower valves or the mitral and the tricuspid in the fourth intercostal spaces, with of course the right tricuspid valve actually lying behind the fourth intercostal space. Then you'd find the aortic and the pulmonary in the third. But in terms of the sounds, right, you actually best hear them in the second intercostal space, that is the your semilunar valves, whilst the mitral valve is best heard at the apex of the heart, which is in your fifth intercostal space, 9 centimeters from the midline, right? Because remember, the apex of the heart is actually directed downwards, forwards, and to the left, right? Then the tricuspid valve is best auscultated in the lower end of your sternum, right? And this picture also gives us a great view of something that you can actually do during thoracocentesis or paracentesis. If you want to drain blood from, not blood, but pericardial fluid from the pericardial cavities, you actually insert a needle just lateral to this sternal joint. It's actually going to be passing at an angle of 45 degrees to avoid injuring the lungs due to the presence of the cardiac notch in those regions, right? Then lastly, we will describe the innervation of the heart. So the innervation of the heart mainly it's going to be via the superficial cardiac plexus, which you find just beneath the aorta, which is in this region. Then you have a deep cardiac plexus as well, right? The superficial cardiac plexus will be formed from branches that are actually coming from the sympathetic branches are coming from the superior cervical ganglia, whilst the parasympathetic branches are coming from the inferior cervical branch of the vagus nerve. Then all the branches of the vagus nerve plus the left recurrent laryngeal nerve, they will give the parasympathetic to the deep cardiac plexus, except the inferior cervical branch that we said was actually going to the superficial cardiac plexus. Then the sympathetic that is going to the deep cardiac plexus, it will come from all three cervical ganglia, the superior, the middle, and the inferior, as well as the upper 4 or 5 thoracic ganglia. They'll give the sympathetic to the deep cardiac plexus, which is actually in this region. You'll actually find it at the level of the bifurcation of the trachea, that is just at the carina, right? Then also from this diagram, we can maybe appreciate the relationship of the pulmonary artery to the aorta, right? This relationship comes about due to the spiraling nature that actually occurs in the truncus arteriosus during embryonic malformation, which is going to place the pulmonary artery just inferior and to the left of this ascending aorta. And if you then look at the aorta is then going to be characterized by 3 trunks. The brachiocephalic trunk, which is this one, which is going to divide just behind the right sternoclavicular joint into the right subclavian and the right common carotid arteries. Whilst this will be the left common carotids and this will be the left subclavians. The common carotids will be going to the head and neck region, and they will later on divide into an internal and an external, whilst the subclavians will actually be divided into 3 parts, and at the outer part of the first strip, they'll then continue as the axillary arteries that will then become the brachial artery at the lower part of your teres major muscle, right? Then, so that's just about it. Then if you look at the interventricular septum, it has a larger muscular part and a smaller membranous part. And this interventricular septum is obliquely placed in such a way that it is a part that is bulging anteriorly on the right and a part that is bulging posteriorly on the left. And the interatrial septum, interestingly, it runs from the anterior wall of the heart going backwards, right? And if it's running from the anterior wall of the heart, it will actually run in such a way you could see. Remember, the interatrial septum was being formed from, from your septum primum, then the septum secundum, whatsoever, right? And it actually runs from the anterior wall of the heart, and it's going to run backward and to the right, right? And the interventricular septum is the one that we said is actually obliquely placed, and it's going to have a surface that bulges anteriorly and a surface that bulges posteriorly. Because remember, the heart is not in a true anterior-posterior axis, right? The right side is going to be more on the anterior side, and the left side is going to be more on the posterior side, which is why we even say that the right coronary artery was coming from the anterior aortic sinus, and the left coronary artery was actually coming from your left posterior aortic sinus, right? Then a bit of clinical correlates associated with the anatomy of the heart. You can have a problem within the conduction system of the heart, and that's going to result in arrhythmias. Then you can have commotio cordis, and commotio cordis will actually result in ventricular fibrillations and sudden death, right? So this is caused by like sort of blunt, non-penetrating wounds that are actually going to cause blows on the anterior chest wall, right? Then your coronary arteries, they're actually anastomos, but the anastomos is not functional to cater for the other side if you were to have blockage. And usually atherosclerosis is more common in these coronary arteries, and actually affects your elastic arteries more, to include the aorta. That will result in aortic aneurysms, but you can also affect the muscular arteries, to include the coronary arteries, and they can actually be blocked, right? Then cardiac pain can be referred to the medial aspect of the arm, because remember the intercostal brachial nerve that was actually T2 was going to supply the skin of the axilla and the upper aspect of the medial side of the arm, right? So cardiac pain can actually be referred to those regions, because remember we're saying that the upper 4 or 5 thoracic ganglia will also bring sympathetic innervation to the heart. And the heart, in conclusion, we say that it is its own intrinsic pacemaker activity, meaning to say that this autonomic nerve fibers will actually help regulate that, with the sympathetic actually increasing whilst the vagus nerve actually decreases. Anyways, that's just about it. I hope you enjoyed the video, and don't forget to like, comment, and subscribe.